Obstetric Anesthesia, Diseases in Pregnancy 1, Hernando de Soto. The lecture modules for this presentation will be to talk about hypertension of pregnancy and the definitions by the American College of Obstetrics and Gynecology on hypertensive disorders of pregnancy. Hypertension of pregnancy. Question. The first-line treatment of eclampsia is A. Sodium thiopental, 50 milligrams. B. Magnesium sulfate. C. Ativan. D. Rush to the OR and deliver the baby. The correct answer is magnesium sulfate. According to the American College or Congress of Obstetrics and Gynecology, that is the best answer. A is incorrect since this drug is no longer available in the United States. Propofol can be used to stop the seizures. C is wrong as Ativan takes too long to work, and D is also incorrect since there is no need to immediately deliver the baby usually. Hypertension of pregnancy can be developed into two: chronic hypertension and gestational hypertension, and either one or a combination of these can develop into preeclampsia, eclampsia, and HELLP syndrome, HELLP being hemolysis, elevated liver enzymes, and low platelets. What are some of the definitions by the American College or Congress of Obstetrics and Gynecologists in regards to hypertensive disorders of pregnancy? Preeclampsia, eclampsia usually happens after 20 weeks gestation. Hypertension more than systolic of 140, diastolic of 90, usually with proteinuria, multi-organ dysfunction like thrombocytopenia, and the worst scenario, HELLP syndrome with hemolysis, elevated liver enzymes, and low platelets. 15% of maternal deaths after a live birth in the United States caused by preeclampsia, eclampsia, usually from a cerebrovascular accident because potential hypertension. Happens in about 6 to 8% of pregnancies, but the key thing, even though that sounds very, very high incidence, about 75% of them are mild, only about 25% are severe, and these severe ones are the ones in the perioperative period that can be sort of a nightmare for anesthesiologists. Chronic hypertension, it would be the next definition, which is usually unrelated to pregnancy, and it happens again before the patient gets pregnant, usually before 20 weeks gestation or before conception. There could also be preeclampsia superimposed on chronic hypertension with new onset thrombocytopenia or proteinuria, and this can have substantial risk to mother and fetus if not taken care of right from the onset. And the last one is transient or gestational hypertension, which is hypertension that occurs in late pregnancy without any other evidence of preeclampsia, no proteinuria, no HELLP syndrome, etc. Completely resolves postpartum with very minimal risk to the mother and fetus. And again, this is called transient or gestational hypertension. The term pregnancy-induced hypertension is no longer used according to the American College of Obstetrics and Gynecologists. Going back to preeclampsia and eclampsia, the etiology is still remains unknown. There's a lot of theories, especially placental ischemia, more recently immunologic origin, and even more recently genetic predisposition. Risk factors usually happens during first pregnancies. If there's extremes of age, considered under 18 or over 35, family or personal history, patients that have used barrier contraception, patients that have had donor eggs or sperm, and it happens more frequently in African American women. We do live in the United States the obese endemia or pandemia, so obesity is a huge risk factor for preeclampsia/eclampsia. Also, patients that present with multiple gestations, twins, triplets, from filials, a lot of diabetes, as part of the obesity nation that we're living, chronic hypertension. There's been many publications in regards to how can we prevent preeclampsia or eclampsia from happening. A lot of the preventive measures that were thought at one time that would work have been found in a lot of recent data to not work. Magnesium, zinc, fish oil, antioxidant vitamins, C and E, and calcium have been all found that they do not work. Protein or salt restrictions, have not been working very well. Anti-hypertensive meds in women with chronic hypertension do not prevent preeclampsia. The use of low molecular weight heparin and heparin as treatment, again, we're talking preventive measures. Exercise, a lot of preeclampsia in patients that are marathon runners, etc. What has been found in a lot of recent data is that patients, when they're placed on low-dose aspirin at a certain point of their pregnancy, that may have some protective effect for preeclampsia. So that's the only one of these issues that have been found to work somewhat. Prediction and diagnostic tools, the SFLT1-PIGF ratio in different types of hypertensive pregnancy disorders have shown some prognostic potential in preeclamptic patients, pretty much because the SFLT1, these proteins can be overactive in preeclamptic placentas. They can be anti-angiogenic, known to thwart blood vessel growth, and measuring these proteins again can predict preeclampsia months before its clinical onset. So again, alterations of the SFLT1 might be used as a screening test for early diagnosis of preeclampsia. Current OB management strategies, really the only cure is delivery. Benefit to mother and risk of prematurity in the fetus have all need to be taken into consideration. Obviously, the idea would be to try to bring the fetus to lung maturity. Neonates delivered vaginally have less incidence of respiratory distress syndrome, and the decision on delivery has to be based on both maternal and fetal assessment and steroids for fetal lung maturity. Maternal assessment, different organ systems, obviously hematologic. They may have a decrease in platelet counts, hemolysis, epigastric pain, increases in liver function tests, neurologic issues, renal, pulmonary, and issues with the placenta in regards to oligohydramnios, etc. Fetal evaluation, the non-stress test of fetal well-being is commonly done. Also, it can be evaluated, the fetus, by ultrasound for amniotic fluid volume, fetal growth percentile, estimation of age, especially looking for lung maturity and biophysical profile. The worst scenario here is if the patient develops HELLP syndrome, which again is an acronym for hemolysis, elevated liver enzymes, and low platelets. Under 100,000 is considered. Steroids in HELLP syndrome can be very, very, very beneficial in these patients. There's a threefold benefit on steroids because they improve the platelet count. So, by having decent platelet counts, regional techniques can be used in these patients. Reduce stroke and death, and much less hepatorenal morbidity. What about anti-hypertensive agents? Magnesium, hydralazine, labetalol, nitroprusside, and calcium channel blockers have all been used Important that ACE inhibitors and angiotensin receptor blockers are all contraindicated in all trimesters due to the potential teratogenicity. So no ACE inhibitors, no angiotensin receptor blockers in these patients. Would also avoid a Tylenol because of intrauterine growth retardations, and I would also avoid diuretics for the chronic management of these patients. Moving on to eclampsia. What is eclampsia? It is a generalized seizures and or unexplained coma during pregnancy or postpartum in a patient with signs and symptoms of preeclampsia. Pathogenesis is usually a vasospasm, vasogenic edema, more important hypertensive encephalopathy, cerebral hemorrhages, and metabolic encephalopathy. So this is a very serious situation that cannot be underestimated. At the time of onset, it can happen before partum, intrapartum, and postpartum, and still consider the first line of treatment by the American College of Obstetrics and Gynecology is magnesium, with a 4 to 6 gram loading dose and infusion of 2 grams an hour to try to keep eclampsia in check. And use an antihypertensive if the diastolic blood pressure is higher than about 105. What is magnesium? Why is it so important in these patients? It is the best protective situation for eclampsia, but it can also have some negative effects. It has some tocolytic properties that can prolong labor and increase bleeding at delivery, may decrease fetal heart rate variability, may depress maternal and neonatal neuromuscular function, can cause maternal respiratory depression, cardiac toxicity if toxic blood levels happen. And if toxicity happens or occurs, it is only partially reversed with calcium. Now, if you look at magnesium levels, obviously normal levels should be 1.5 to 2, all the way up to 25 for cardiovascular collapse. Now, who needs magnesium? There's tons of study out there in which if you treat mild preeclampsia with magnesium, you would need to treat 400 women to prevent 1 seizure. If it's severe preeclampsia, you would only need to treat 129 to prevent 1 seizure. But if it's severe with symptoms like visual effects, etc., or visual symptoms, then you would only need to treat 36 patients to prevent 1 seizure. So obviously, the more severe the preeclampsia, the higher the need for magnesium. An eclamptic seizure, how do we treat that? Obviously oxygen by either mask or intubation. This is currently still very controversial in the literature. I personally tend to think that if there is an obstetric patient seizing, I would protect the airway with intubation. But there is, again, controversy as to whether that is necessary or not. Obstetrical patients are at risk for aspiration, so I personally would intubate those patients, and that the majority of people in the literature would agree to that statement. You have to stop the seizures with either propofol and or benzodiazepines, additional magnesium, intractable seizures. You would need to rule out a cerebral bleed, so these patients may need to have a CT scan or an MRI, again, to rule out that cerebral bleed. And then the form of delivery becomes an issue here. In the past, historically, these patients have been rushed to the operating room for an emergency C-section, and now some recent data has put that that statement into a big question mark with vaginal versus cesarean section as alternatives here. There's a recent publication in which they looked at whether patients that have Cs need to have an emergency C-section, And the conclusion was, and I quote, a policy of early cesarean delivery in eclampsia carrying more or equal than 34 weeks is not associated with better outcomes. So again, putting into question recently the old philosophy of rushing these patients to the operating room. Thank you very much.